Good afternoon, everyone. We're getting ready for our panel session. I know that we all wish the breaks were twice as long to catch up and continue these great conversations, but we know that we want to move on with the content in the agenda. We have about 40 minutes for this panel to speak today, so we're going to go fairly fast. Each person is going to introduce themselves. I'm Shaun Grannis. I work with Chris Bartlett to lead the Real World Evidence Core as part of MPRINT. This group today, what you're going to hear about are experiences with real-world data as it pertains to maternal child health. And so you're going to hear discussions about phenotyping, you'll hear discussions about maternal child matching, and you'll probably hear some discussions about other things, other challenges related to dealing with real world data in support of maternal child health research. But this effectively makes up a significant portion of our real world evidence core for the MPRINT. And we have some great speakers here today. So without any further ado, Chris, I'm going to turn it over to you.
Right. So I'm Chris Bartlett. I'm the Associate Chief Data Sciences Officer for Nationwide Children's Hospital. I'm in lieu of, we want to get more of a discussion going. So I actually waived any slides, and I'll just say real quick some stuff that we're doing at Nationwide Children's. And then we're doing a lot of maternal linkage, but you're actually going to hear the specifics from the two speakers on my left here. But just so you know, so at Nationwide Children's Hospital has recently started investing heavily in real world evidence. And so this is one of the things in my portfolio right now is to expand that our offerings in the cloud and also doing a lot more linkages with other data sets. I'm very excited to see the N3C model maybe being expanded, because then there's certain things that we won't have to do locally anymore. We can just do that nationally with N3C. But happy to have a discussion.
Are they over here or not? Medina, are they there or not? I can talk without the slides. That's okay. Yes. So he gets the slides there. I think one of the graph that I think would be nice for people to see. But Eneida Mendonca, I'm a pediatric critical care physician by training. I also do work with data analysis. I have my PhD in Biomedical Informatics. I'm a professor of pediatrics and biomedical informatics at Cincinnati Children's Hospital, University of Cincinnati, and I lead the division of biomedical informatics at Cincinnati Children's Hospital. And I'm going to talk about our maternal infant data hub at Cincinnati Children's. And part of this conversation is not going anywhere. Can I do it on the computer? Just click again. Great. So I think most of you know Cincinnati Children's. I just put this slide here because it's a large tertiary quaternary hospital, but has a lot of clinics associated with that, which is important in the conversation we had. And I need personally apologize to Ken. I asked him a hard question that, he asked Shaun for help, but I'm going to try to show you here how we are actually dealing with some of those questions when we need to deal with this in our own locations, right? And when we do things like together as partners in a project like MPRINT, where we are trying to bring data from these different institutions together, how hard that task is. So at Cincinnati Children's is the largest hospital. We have data there, but the mothers are not there, right? The mothers actually give birth at the University of Cincinnati Hospital, not at Cincinnati Children's Hospital, unless it's a high-risk pregnancy. So the data is not at Cincinnati Children's, the data is at UC Health. We also have a project called Every Child Succeeds, which is a program with home visits for pregnant women and small children. So that's data from the ambulatory side, right? It's, again, not in the data from the hospital, right? So, but it's important data for us to follow when we are doing longitudinal studies, like was mentioned before, or when we are doing outcomes studies, we need to have that data. And we also have the Newborn Care Association, which is physicians and other providers that take care of the babies after they are born if they are not at the hospital. So we have all this different data that we need to plug together. And when I ask the question, is really what we need to do with this. You see the liver. So you see the green is where we deliver the data, right? And then we see, and at the same time, we have the Every Child Succeeds project, where we take care of the moms while they're pregnant. That's, again, outside of the hospital, and the babies after the hospital. So all this data, they align together. And on top of that, if by any unforeseen circumstances a child dies, not always they die at your hospital. Sometimes they die somewhere else. So you also need the death certificate, right? And you also did birth certificate. So putting all this data together is what we've been talking about, right? This is the kind of challenge that we have. This is just to give you an overall data. So we have about 34,000 matches in our maternal infant data linkage. This started with 70,000 moms who were pregnant at a UC Health Hospital. And from there, we had to do a lot of algorithms to try to merge that data and try to figure out what are the real pairs, right? How can we put a mom and a child together, a child that is receiving care at Cincinnati Children's? This is just to give you, I don't want to spend much time in this, just to give you the pairs, but what is interesting here is the matching algorithm that we use and how we are trying to solve that problem. And as you can see, we use several different sources of data, which are the ones I mentioned to you. You have several different, other data points that we actually need to look at it, but not everything is right exactly the same way, right? You can have, I think Ken mentioned weights, right? You can have weights that are different. So you have something in the kid's record, something in the mom's record for the birth. You have all these things. So we actually have a 13 kind of stepwise approach to really match those kids to the moms. And we did do that once, and we did that twice, and we actually validated that. So now we have an algorithm that can actually bring all this data together. But when we see the data, in the maternal infant data hub, the data that we can use for research to do longitudinal studies, outcomes studies, both on the maternal and the infant side, you have data from all these different places, right? And all that data needs to be combined. And we do have our data in a NOMOP data model, same as Entry-C. We are working in automating more of that data capture right now, trying to do self-service tools for the investigators. So where they can actually go there, visualize data, do feasibility counts, and understand that data better so they can actually do research and linking to other resources. All our data is already linked to the geospacing analysis, so we can actually do environmental work. You can look into parks. You can look into what we have around the houses. That is already done, but we are now linking to the genetic side of the data, right? We have a couple of partnerships that are looking to that. But the important thing here is that some of our kids also are born not at UC Health, are born in other hospitals in the city, right? And how then is the legwork that Ken was mentioning about, right? We had to go to each one of those hospitals and promise them we are not going to de-identify the kids. They promised them the mom's data will be safe, that we were going to bring it. It's going to be de-identified for the investigators, lots of data users agreements, lots of conversations, governance, because each hospital has its own data, right? And you have several in the region, and not only in our state, but also in Kentucky, which is across the bridge. So to complicate a little bit more and not counting not on that, we have the South Indiana, which are also part of the thing. So when you see all of this, you see how complicated this can be. And it's all about that conversation, data acknowledgement, trust. We need to build trust, right? And that's the form of doing this. And in this trust, we create all these agreements to be able to bring all this data together for us to be able to linkage all of that. And I will stop here because we want to have a conversation about that. And And Dr. Colin Rogerson is gonna show a little bit more about the Indiana side.
Right. Thank you for the opportunity to come and present to this group. It's wonderful to be here. My name is Colin Rogerson. I'm a pediatric intensive care physician at Indiana University at Riley Children's Hospital. I'm going to talk a little bit about some preliminary results of our maternal child matching algorithm that we're developing as part of the real world evidence core. So we're starting it here at Indiana University, and then we're adapting it for our partners at Ohio State and Cincinnati. I have a couple of introductory slides that I'll go through pretty quickly, and then we'll get to the results. So my colleagues have talked a lot about real world evidence and the challenges in working with it. So I'm going to go quickly through that piece. One of the challenges we face, again, if you have a patient that's seen in multiple different healthcare systems, how can you match that patient so that their different electronic medical records all link together using just what's collected in the routine process of patient care? While that's challenging enough, now we're seeing if we can do that, not just for a patient to themselves, but now if we can do that for a mother to their child's record, again, using just electronic healthcare data that's captured in the routine process of patient care. So that's really the question that we are, one of the first questions we're attempting to answer in the real world evidence core. And we've started that process, and we do have some preliminary results from just the Indiana data. So a little bit more background about our methods. We have data in Indiana. We actually have a couple of unique data sources. So I'll talk a little bit in a minute about the Indiana Network for Patient Care, which captures electronic healthcare record data for almost the entire state. We started though with our two largest healthcare systems, which is Indiana University Health, and then kind of the county hospital called Eskenazi. And we have full access to both of these electronic healthcare systems, and we use those to develop the matching algorithm. So our initial population, we looked at what records could be counted as potential mothers. And so we define those as females between the ages of 15 to 55 years old at the time of a potential child's birth, and then the potential children had no restrictions in the cohort. We had a gold standard data set developed by Dr. Quinney and others at Indiana University called the Building Blocks of Pregnancy Biobank. This was prospectively built, and it contains 3,615 known matched mother-child pairs. What we used as controls is we looked at the whole Indiana Network for Patient Care, which has well over 2 million patients in it. And we randomly selected 15,000 records and used these as control patients that are don't have a 0% chance to be mother-child linked, but very, very low. These are the specific variables that we pulled out of every patient's electronic healthcare records. For the first name, last name, we use something called a last name metaphone in 2 different systems to capture that, which has to do with how the sound of a patient's last name. And we had to do this for a couple different reasons. One of the biggest is that you have either misspelling in names or you have hyphenated names that don't exactly match up in the record, but they sound the same. We use street address, phone number, birth dates, and social security numbers. Another thing that we faced is that if we were to try and match millions of records with millions of possibilities, it gets very computationally inefficient. And so what we established were what are called blocking schemes, where we set criteria where charts had to meet a couple of different criteria and a blocking mechanism to be considered as a potential match. And if they didn't meet these, then they were not considered in the algorithm. And so this is the table that has the different blocking schema that we used. So I have the acronyms up and then what they stand for. But basically, the last name had to match to either the address name or address number or telephone number, or the metaphone, or the telephone number had to match up to the address number or the address zip code. So these are the 9 blocking schema that we had, and to be considered as a potential match, they had to meet at least 2 of the blocking schema before the algorithm actually would calculate a probability. We used both methods of agreement and disagreement. So agreement would be things like last name, address, and phone number had to match. And then disagreement, things like first name, social security number, and birth date should not match. So we use the known pairs from the building blocks of pregnancy biobank as our cases in the machine learning model. And then the INPC 15,000 randomly selected cases were the controls. We applied these only to IU Health, their Ashkenazi records that we had clinical notes available for, and what's called a mother-child flag. So Epic specifically has a flag in the chart that says if this is a mother-child match. Not every Epic case has this, but for the Ashkenazi cases, we're pretty reliable. So we use that as kind of our metric to establish how accurate the model was. So we then applied this to 221,000 potential pairs pulled from the Indiana Network for Patient Care. And based on the flags in the records that we had, we established 20,000 true pairs and 200,000 true negatives. And then we used what's called an XG boosted machine algorithm and developed this predictive confusion matrix. And overall, we can see in the block on the right, the true negatives in the top left in the yellow, and the true positives in the bottom right in the more bluish purple. And then the middle, the bottom left and the top right were false negatives and false positives. And the block, the graph B shows the feature importance metrics of which variables were the most important in predicting pairs, which turned out to be the telephone number, the city name, address, and zip code. And so using that, we were able to predict these metrics. And so as you can see, the negative predictive value is very high, which you would expect because most cases are not going to be matches. The positive predictive value, again, these are preliminary results, but turned out to be about 7.75, meaning that about 3 out of 4 predicted positives turned out to be true positives. As I said, we have some next steps as these results are promising, but not quite as good as we would like them to be. So we have some refinement that we're currently in the process of doing to improve the positive predictive value. And then the goal is once we get a accurate model, we're going to apply this model to data from other health systems to show that it works not just in Indiana with our health systems, but for other sites with other setups. So I want to acknowledge everyone here on this panel, as well as several others that have helped with this preliminary work. And I know the rest of the time is dedicated to the panel and discussion, but happy to answer any questions anyone has. Thank you.
We also have Wei on the panel. Wei is here to sort of be a reactor and respond to any particular questions in his area of expertise. But Wei, I didn't know if you had any thoughts or comments about what's been discussed so far before we go into that question and answer period.
I think this is great. It's a very great start. Maybe I can just speak something about the general phenotyping. For people who don't know me, my name is Wei Qi. I have been doing phenotyping for a long time. And I also chair the eMERGE Network phenotyping work group for a long time. And I guess some big lessons we learned from the eMERGE Network. Number one is if you find the right person, find the right group, and find the right collaborators, you can build up a very nice phenotyping algorithm. I have no doubt about that. That's what we learned from eMERGE 1, 2, 3. And super nice performance. But the potential issue is super expensive. Let me say that. It's for eMERGE Network, we have spent like 15 years to probably generated like slightly over 80 different algorithms. But remember how many diseases are out there. If you're looking for the drug outcomes, that's basically impossible to do that. It's just probably spent hundreds of years. And so in my lab, one important thing is how to improve the phenotyping performance, how to do that better. You have a semantic knowledge-based approach. FECODE is a great example. And another thing is like you can leverage literature mining, combine the concept together. FAAP is a great example. And also right now you have the AI. Happy to talk about that. Is large language model can really help you to start the draft the phenotyping algorithm. And another thing I want the group to really think about is if you generate a very nice algorithm, how can you share that with the other people to replicate your findings? This is super important. Think about this. A lesson we learned from the eMERGE network is that right now we're on eMERGE 4. So that's but the first algorithm we generated as a type 2 diabetes algorithm, generated by Northwestern, that's 2010, 2009. But remember that's algorithm majority are based on ICD-9 codes, and we miss a few new medications. So maintain the code and share the code with other people. That's going to be super, super expensive. So I'm happy to be here and just share our experience, and happy to listen to your guys regarding, how to improve the phenotyping field. Thank you.
We will open it up to questions at this time. See what questions, comments, observations people have. Lang?
Yeah, if you don't mind, I'm gonna open up. I heard the words expensive. I heard the words not easy to share. I want you probably can expand a little bit. How do we do it? I think it's, let's say, linkage algorithm, right? If you, let's say, after 3 to 4 years, and we have done quite a bit, right? And if you're looking back, what can you do to make it more efficient, to make it less expensive, in terms of standardize the algorithm, phenotyping algorithm across multiple institutes?
I assume the question is for me, right? So, okay. Yeah. So I think, so when we talk about the expensive, how to improve the performance, we need to look back to see, which part we really, I would say waste lots of time doing that. So my experience is like discussing, polish the algorithm and draft the first algorithm. That usually take lots of time. So so I guess, in my opinion, so far, how to find the right way to start the algorithm, reasonable good performance algorithm. That's possible. Think about this. If you've got a large language model help you to do that, I'm not saying large language model can really give you a final product. I'm saying that can give you a reasonable good start point. So that's one point. And number two is, you need to find a real, I would say, group who understand both informatics and also, the clinical domain to help you polish the algorithm. That's very necessary. If you find the right person, that's going to save your time. Then the third one is about if you're looking for the cross-institute, performance, you need to find a collaborator to help you, I will say, doing the validation. That will give you the general performance, I will say.
We have multiple.
I was just going to talk a little bit about, you asked 2-point questions. You talk about the models and how we do that, but there is the linkage first, right? In our case, I think this is something that we need to be doing and getting more of the leadership to think that this is important. Our maternal infant data linkage started as one component of a CTSA grant. So thank to NCATS, who funded that initial approach. But, initially you have to do all this legwork and bring, but if we really look and think, some of this data is already there for clinical care, right? How can we are now trying to do in a different way, trying to automate from clinical care? We have, for instance, a lot of our institutions there have the same system, which is Epic, right? We have care everywhere and it brings data from all of it. You cannot bring that for research, you can bring that for care. How about if we start talking with the institutions to try to have them to also agree that they will share for research and not only for care. And that's one part that we're trying to do to reduce the cost, because we are paying for, all this processing of data. And I'm going to say the word ETL, and please don't ask, because I'll ask Shaun I know what it is, but I'll ask Shaun to explain. But we pay for all these processes twice, right? One for research, one for care. And we keep paying them, and it costs a lot of money, right? we need to think about maintenance, and as things grow, how do we move forward with things that grow? And I think that's an important component, which is totally different than the modeling, but you don't have the modeling if you don't have the data.
Talk about this topic for quite a while. Why don't we go on to the next question here, and we can always loop back too.
You had shown some nice results with the predictive performance on the maternal child algorithm. I was just curious. You said it wasn't good enough. What's good enough? And then can you quantify good enough for a certain context of use for an application of the algorithm?
Yeah, no, that is a good question. Again, this is one of the first groups that has done this on a large scale in this way. I think if you're looking at thousands of records, then knowing that 1 out of 4 is not an actual linkage, it's a false one, is too much. I can't quantify that to say that we have proved that that's too much. It just sounds like it. I don't know. I think, and Shaun is kind of the expert in this realm, so I'd defer to him, but I would like to see 90% at least or higher. But what do you think, Shaun?
So the question you ask is a hard one, and the performance is always related to the particular fitness for purpose. So we find when we do linkage studies, for example, for population health, for our public health partners, they want to, compute the incidence of childhood obesity. They actually err on the side of false positives, meaning they want to make sure that they capture the entire population. They want to maximize sensitivity. So they're willing to compromise a little bit on that specificity or positive predictive value. On patient care, though, we want to fiercely defend against the false positive. And so we often are happy with a positive predictive value. Well, no, let me take that back. We're often happy with a sensitivity of 80% if it means that we prevent the false positives. So the answer to the question is it depends, but I agree with Colin. We want to see that number significantly higher. The other thing I would say is what we often find in the practical real world, once we have some sort of method or algorithm in place, some sort of probabilistic approach, we very often layer on business rules to eliminate those false positives. In fact, if you look at all of the commercial matching systems out there, that's exactly what they do. They have their secret sauce matching approach, and then for different implementations, you see they create the capability for local installations to modify the output to meet their needs. And so we get rid of a lot of those false positives, frankly, by building business rules.
And there's one more layer to this, that the big number of even say 96 or 97% accuracy or precision or recall or whatever that number is, you can say, well, that's pretty good. That's always the place to start. Then you have to unpack what's remaining, right? Because there's, for example, folks who are lower income may be much more mobile and the addresses don't link because there's a failure on that part. That causes a bias in the data set. And so to combat that, one needs to go and say, well, of the things that we couldn't get the easy way, what's the hard stuff? And is it something that's feasible? And if it is, you got to do that work too. And so when is that number good enough? I don't know, but this is just the first step. The next step is to check all that other stuff out, because I think bias is something you always have to fight and pay close attention to.
Yeah. So Aaron Pollock, NICHD. So I've gotten a pretty good understanding now of some of the utility of what can be done in terms of maternal infant linkages, both in terms of, in terms of exposure and pregnancy outcomes. I'd like to shift to pediatrics for a little bit, or focus on pediatrics. So for any of the panelists, could you just maybe comment on some of the potentials for using real world data specifically for pediatric populations? And that could be, from neonate through adolescence.
Okay, so we're going to talk a little bit about pediatrics. So in addition to the longitudinal studies, as I mentioned, we've been doing a lot of work with prediction modeling as well, and also trying to identify different drug toxicities or repurposing drugs for pediatric care. especially it's very hard to do clinical trials in children, and it is expensive and it's difficult, and trying to the same way pragmatic clinical trials is what we are trying to move forward with. So there is a lot of movement going on over there, a lot of artificial intelligence, machine learning involved in looking to some of those data sets that bring, but it's having the mother side of course helps us. For instance, if there is any exposure at that point, bringing all this data with environmental genetics, which is what we are trying to do together. We are even bringing circadian rhythms now to some of those analyses, helps us to identify even where's the best time to give that medication to a child, right? What is the best, pharmacokinesis of that, for the pharmacogenomics, the pharmacogenetics, and all those components. If you see the child as a holistic thing, right? Not only pieces of a child. I don't want to look only at social determinants of health, or I want to look only just on the genetic part. No, we are trying to put all of this together and create such an environment that we can actually look at every single piece to solve the puzzle. So I think that's where in the pediatric side I would go, and I would go all the way to the pediatric side. A little bias hat.
Yeah, and the only thing I would add to that is this is a little bit anecdotal, but again, I work in the ICU, and so we have a lot of kids that come in repeatedly for a lot of times the same illnesses, and we do extensive workups, we do genetic testing, and we don't really seem to find a reason, but they continue to come back. And this is one of the proposed mechanisms to try and identify that. Perhaps there is something in mom's history or something in mom's pregnancy that led them to have underdeveloped lungs or GI system or something like that. And this would give us another option to study where we currently don't have a way to look at that.
Yeah, rare disease is right there, right? So if we have more on that, it's very difficult. You have 1 or 2 or 3 or 10 children in a place, right? But if you look at data from different places, you can have a better sample to really look and try to identify new patterns that we don't recognize before.
Yeah. I'll go for it.
May I just add 2 points? I think the number one is, for EHR research, chart fragmentation is a huge issue. I guess compared to adults and children, kids probably we got a better chance to have a relatively complete medical records in a single medical center. So let's give you EHR research a big advantage. That's number one. Number two is regarding kids. If we follow up for a long time, we will have the kids the whole life medical records there, right? That's huge.
I'll just throw in my 2 cents here for Aaron's question. Real world evidence is what you can do with that really is certainly it's going to be determined by the types of data collected for those populations. But the strategy is similar. We often don't want to conduct the research or can't conduct the research on a particular cohort, either for ethical reasons or economic reasons, et cetera. So I mean, it's as the panelists have already said, there's lots of examples of that. I think you need to strategically think about real world data with pediatrics in the same way you think about real world data for other things. I think it can be informed by the actual studies that have been done. I just want to layer on using our real world data. We're a significant contributor to the CDC's vaccine effectiveness work. And we were one of our data helped identify the myocarditis in young men as part of, if you remember during COVID. So I think there's a lot of potential power in this data to be used, and it isn't just for adults anymore.
I will throw a little more word in that, learning health systems.
So my question is driven by my interest in outliers and goes back to the comment about the importance of definitions. So I will just ask you this question about outliers. How do you deal, especially if you're looking at maternal exposure and infant adverse effects? Who do you define as the mother when it's a product of an in vitro fertilization?
I think that's a very good question. And I think that a child may have more than one mother. So in my definition, a child can have more than one mother, including a grandmother that sometimes is a mother. I think it will depend. I think in the genetic part, of course, the biological mother is the one that's going to matter the most. But a child may be living with somebody else, or a child may be in foster care, or a child may be alone. And I think the environment, that's why I think it's important to bring and look at the child as a holistic approach, and not just looking, here's the mother. Sometimes the mother is a father. Sometimes the mother has nothing to do, is a male, right? So I think it changes. I think if we look at the children as in a child specifically, as what is around that child, right? What is the environment around the child is when we actually start really understanding that child. Just looking into what we prescribe as society as the right way of doing or not doesn't cut for us, right? You need to really look into that. And in some cultures, there's the cultural thing about the families as well. I'm from a Latin country. There is no just one person in the house. There's like 10, right? And you get to a kid, to a pediatrician, that comes mom and the aunt and the cousin and somebody else. And this is everybody in there, and everybody has something to say, and everybody took care of that child for one period of time or another period of time. So I think we need to look more at the holistic approach and trying to really understand instead of just taking the data as that one point single variable.
We have several other questions out there, and our time is running short, so I want to move on if we can, if that's okay with the panelists. I thought you were next, but okay. Yes, you're next.
Gina Simone, MS, and in support of the BPCA program. I have 3 questions, and we might not get them all today or in this session. But one, NIH has a mandate for all of us who are doing clinical research to put that data into public data repositories. That data is cleaner. You already have user access. Are you going to suck up our data? I hope you will. The second question is, my children and certainly my grandchildren, it will be taken for granted that their data lives out in the cloud and everywhere else. We talk about institutions owning and giving you access to that data. What are we thinking about for the future where the person owns the data? And that really leads into my last question is in pediatrics, we want to study kids longitudinally. Nobody can afford to do it in clinical research. Primary care physicians aren't doing it. What can we do through these databases? As a woman or anybody, names are going to change, addresses are going to change. How will we follow these children long-term? And I'll sit down. I know it's a lot.
Do we have like 4 days to answer your question?
Well, yeah, I can take a crack at that, and I'm going to go quick here. Do we want to? Are we inclined towards public repositories? Absolutely, recognizing that there often can be challenges to that, but to the extent that that's feasible, I would like to see that happen. Data in the cloud, I'd be surprised if everyone's organization here doesn't have some data in the cloud. It's happening, and I think it will continue to evolve in that direction, which means we have to have excellent privacy and security controls in place for that. And number 3, page longitudinal. As a family physician, I would say we've been doing longitudinal research in pediatrics and family medicine. Right. Right. And to the extent that data becomes more standardized, more integrated, harmonized, these capabilities will expand and we'll be able to do much more of that. But great question. We could spend all day talking about it. What? Yeah. Yeah. Yes. Yes.
Great, thanks. Tamara Lewis from Sick Kids in Toronto. My question is about using real-world data to create in silico control arms for pediatric clinical trials, and you guys' opinions about sort of this critical interface between the data that live in academic institutions and the pharmaceutical companies that need access to this data to create in silico control arms, and sort of how real-world data can play an important role in that space?
I didn't quite hear the adjective before control arm. What did you say?
Basically using real world data to create in silico.
Oh,
control
okay.
arms.
Yeah. So synthetic data.
Yes.
Yeah. Okay. Does anybody want to talk about synthetic data here? Okay. Well, I just don't want to take up all the time. Okay. Synthetic data is showing real promise. There's been a few publications in that space showing its fidelity to real data. There are gotchas with it still. I think we're still learning a lot about how to ensure that synthetic data shows fidelity to the original data itself. And so I think practitioners using that data need to ensure that they understand the characteristics of that data. I think synthetic data will continue to grow in popularity and value and use over time. We have used I don't want to go. We can talk about that in the break if we want to, but I guess we're excited about it. We think there's a lot more to learn, and I mean, I think in a lot of statistical studies I think a lot of people have taken the background population distributions and created created matching. That's not an uncommon thing. So the in silico process, I think it's been around for quite some time. I think now people are really getting into it in order to make the claim or the guarantee that this information is accurately reflecting the characteristics of the actual data it drew from. And we're getting better at that.
Thank you so much. I'm Maureen Shin. I'm a clinical pharmacology fellow from UCSF. I think my question falls in line very similarly, but I was very curious about your thoughts on the implications for data management in prospective trials, mainly because at our institution, we have data managed in a variety of different platforms, and that may or may not necessarily be on the EHS system that we use. So in that context, I'm wondering your thoughts on how institutions can better, put either data together or have better regulations for collecting data and the implications for any changes in regulations for data management, especially when we're working with other institutions or governments that may have different standards than from like a data collection perspective. Thank you.
I can talk a little bit about our experience. If you are participating in a multi-site study in general, you are more guided by those principles, right? With the more data quality, we participate in several networks of pediatric studies, from rare disease to cardiovascular to cancer. Those are more regulated, but still we just did in our last count 380 longitudinal cohorts in our institutions, and they don't talk to each other. Data was collected in different ways. In the past, some are old, they continue, some are new, that are starting, some are in the middle, and it's a lot of work. It's a lot of work. I had the privilege to participate in one of the ECHO programs with the CRU database, which is in asthma, and my team was the one doing data harmonization for the 12 different cohorts we had with kids that were from, patients that were from 0 to 30 years old already in those longitudinal cohorts. And it's hard. It's really hard. Sometimes you have to do a little bit more. Our institution is really active pursuing a way to provide more of that guidance in data collection, in harmonizing the data, in putting in common data models. Some are easy, but again, we don't have one different data model. There's interpretations. I may implement OMOP slightly different than Colin implements OMOP at Indiana, and then we're going to have to harmonize. But at least it's a starting point where we are starting from one standard, right? Currently, all these studies are not starting from anything. You create the variables, you create the names, you create terminologies. We are not used to get studies and use standard terminologies, right? If everybody uses one particular one, people may use SNOMED, people may use ICD, people may use, some others, and gene ontology and so on and so forth. If we can actually get there, I think we have, we will solve the problem, but it's hard. It's very difficult because people experience were
in the way before, right? You do your study, you define your variables, you define your data collection forms. You do the way we think you do, and sometimes you put a lot of text in there as well, right? So there's ways of dealing with all of this, but it's a time-consuming task. But yes, I agree with you. I think we need to talk more about that and teach the new generation to really pay attention to some of those guidelines. I think we need to really do more on the PhDs and graduate programs and medical schools and nursing schools and so on and so forth to really talk about data. We don't talk about data in medical schools. We don't talk about data in nursing schools. There are 5 institutions in US that had, data and informatics in their curriculum. How many medical schools we have. And I'm not even talking about nursing schools, physiotherapy, et cetera, et cetera. I don't know if anyone want to say anything else.
I want to get to the last question here, but as we're talking here, rightly so, we're in the context of researchers, scientists, data scientists. So we're talking about sort of those informational, those technical. There are data governance issues related to just there are human beings underneath the management of this data. And as you think about pulling data together from many different sources, you have to make sure that, number one, you're following an established set of guidelines, which means you have to set up an established set of guidelines. Often that's captured in some of the data management plan. But also there is, quite frankly, every time you want to share data or collaborate with somebody, you have to answer the question that you're going to be asked, which is, who are you and why do you want my data? And that's a super important aspect of this. In addition to all the methodology, the standards, the technology, the algorithms, the phenotypes, there is the very human aspect of this work that, frankly, is usually where things fail. It's less often in the technology space. It's much more often in that data governance space, the human interactions where things get really challenging.
And I think one thing that I just said, and I'll get to your last question, is I think also important on that harmonization and that kind of guideline, we need the governance through the institutional review boards. If you're doing a study, you can only share with that group. Even if you do the harmonization, you cannot just plug all this data together in a database and let everybody look at it, because there is a consent form, right? A consent and assent that we need to pay attention to. And just to get a little plug in there, sorry, 20 years of IRB.
I'll make it quick. I think there's when you look at the therapeutics in pregnancy, and just following back Aaron's question, typically we're looking for either toxicity for the mom, or side effects for the baby, short-term and long-term, and dosing. So based on the data that you have and all the work that you've done, you can talk about how to follow up the kids and then different medical records, and it takes forever to harmonize them, and then maybe there's a lot of errors in them, and maybe it's good, maybe it's not. And then whether regulatory agencies like the data or not, that's a different story. How do you work with dosing? How is any of this work going to help us figure out what's the optimal dose to treat a pregnant mom with certain condition?
Yeah, that's an important question. And we have worked, well, not me specifically, I don't work with dosing, but we have investigators at our institution that actually do some of that work. And some actually look into repurposing of drugs and administering different doses at the time. We had, for instance, one vitamin D, for instance, that was institutionalized as a new guideline for our patients with certain types of cancer, because it was changing the way the cancer medications were affecting those patients. So we actually now have a different dosing for the medication based on giving vitamin or not for that particular patient. So there are ways to look into that. If you want to really then, and we are looking into some, maybe you can talk about your work where you're looking into some of the dosing kind of approach for looking into EHR, where and when you give that dosage, I think can be done. But if you really want to do in a trial, you could do a programmatic trial, you could do it in different ways.
there is ways we can try to do some of that work. May not all the work, but some of that work.
All right, great question. I think there's a lot more to be done there. And we hope that you can help us figure those things